Rachel, you're leaving us in suspense with that newest podcast is in the chat.
Sorry, I was fast with my enter, but it's A Bit of Optimism by Simon Sinek.
Oh, very nice. I've heard good things. Some ABBA to start the day. That's always great. Set things on the right tone. For those that are just joining us, if you could please drop your name, the organization you belong to in the chat, as long as your response to the question, your favorite thing to listen to while you drive, whether that's a podcast, a genre of music, whatever you listen to. I'm gonna have to go back through this chat afterwards and compile all these recommendations to send back out to everyone. There's some good stuff in here. Ooh, Stephen King. Too spooky for me. Ooh, the Lord of the Rings soundtrack driving through the mountains. I haven't thought to do that, but I definitely have to. I listen to Lord Huron a lot and the Lumineers when I go in the mountains. Seems to fit the vibe. All right, we'll give it just 1 or 2 more minutes here. Again, for those that are just joining, please drop your name, your organization, and your response to what you listen to while you drive. What's your favorite thing to listen to in the chat before we get rolling? All right, well, I think we can get started. Again, if anybody's still joining, please feel free to drop those answers in the chat as we get checked in here. We use the chat to take attendance for the Learning Collaborative, so please make sure to drop at least your name and organization, but I also am really curious to know what you listen to while you're making your way to work in the morning. But thank you for coming to this month's monthly Learning Collaborative. For those that didn't meet me last time, My name is Conlon Bass. I use he, him pronouns, and I'm the new Zero Suicide Coordinator for the Office of Suicide Prevention. So it's really nice to meet and see all of you. I am really looking forward to today's session and the learning collaboratives in general. If you or anyone in your system wants to be added to the learning collaborative list that isn't already here, you can just shoot me an email and I'll be happy to add that to you. And if you have any suggestions for what we can discuss at these meetings or special topics you'd like covered, please feel free to reach out with those too. But today, our learning collaborative is going to be focused on elevating lived experience in your health systems. We're joined by Jess Stolman-Rainey from Rocky Mountain Crisis Partners. Super looking forward to that. And as we get started here, please feel free to use the chat for comments, questions, any clarifications. I'll be trying to monitor that as we go. And before we do that, I wanted to give some context about what lived experience is, using some definitions from the Suicide Prevention Resource Center, just to frame what we're talking about today. So lived experience is defined as personal knowledge about the world gained through direct, firsthand involvement in events, rather than through representations constructed by others. I'll get to that second quote in a second. Relevant to zero suicide, life experience of suicide generally includes those who have suicidal thoughts, behaviors, those who have attempted suicide, those who are supporting someone through a suicidal crisis, and or someone who has lost a loved one to suicide. And that list's definitely not exhaustive either. The second definition, lived experience, is also defined as experiences of people on whom a social issue or combination of issues has had a direct impact. And as I was reading that definition, I was kind of smiling to myself because I think that applies to just about everyone in the world. But in particular, for lived experience, I like that it incorporated that social factor and that people are influenced by these social factors in different ways dependent on the person. On an individual level, everyone will have experienced this in a slightly different way. And that's why it's so important to include those with lived experience in your health systems. It's vital to ingrain lived experience in your QI efforts, and this really helps bolster your suicide care pathways and save lives. You'll hear much more about that in a much more eloquent and compelling way from our special guest speaker today, Jess Stolman-Rainey. Jess is the Director of Program Development at Rocky Mountain Crisis Partners. In her words, Jess is a mad, queer, feminist, suicide attempt survivor and care worker. And for those who don't know, Rocky Mountain Crisis Partners provides the statewide crisis lines and the RAIN hotline, the Colorado Lifeline, and others. She has spent her career creating pathways to intersectional, justice-based emotional support for marginalized communities, and she believes that mutual aid, disability justice, abolitionists, and other liberation ideologies are integral to solve the problems that lead to suicide. Her work has been featured in USA Today, People Magazine, Mad in America, Mental Illness Research, Education and Clinical Centers, Postvention and Action, the International Handbook of Suicide Bereavement, Crisis, Death Studies, and the Suicide Prevention Resource Center. And she holds the lived experience seat on Colorado Suicide Prevention Commission. So needless to say, we're really excited to have Jess here with us today. And I'm gonna stop sharing my screen and let Jess take over and present. Thanks for being here, Jess.
Yeah, thank you. Let me get my screen sharing real quick. All right, can everyone see? And it's just my slide, not all of my background notes and stuff. I always
Yep, you're
show
good.
my notes on accident. Okay, great. Thank you all for having me. I'm really excited to be here and just talk about the ways that we can really honor and include people with lived and living experience in our work. I think there's tons to learn. We've done lots and lots of research about and on the folks who are interacting with our systems, especially those who interact with our systems in ways that have good outcomes for them. But there's this whole population of people that doesn't necessarily have that same experience, and there's so much to learn by involving those folks in our work as well. So we're going to talk a little bit about that today. I have like a little intro slide, which I won't read because it's lots of stuff and you can look at it on the slides later if it's interesting to you. I'm a person who has experiences with what gets called psychosis, and I am a suicide attempt survivor. I'm someone who lives with pretty chronic suicidal thoughts, and I've been working in the field for quite a while. I have a podcast that you can check out if you're interested. That's called Suicide and Stuff. We're on a little hiatus right now, but there's lots of episodes of that. There's some bad language in it, so if that's offensive to you, you might not be excited about it. So just as a heads up. I wanted to just also take a moment and acknowledge that I am doing this work right now from Denver, Colorado, which is land that was stolen from the Arapaho, Cheyenne, Ute, and Sioux people, and our occupation of their land and the genocide that was surrounding that is still impacting folks today, and has a great contributing factor to the suicide rates of Indigenous people here. And I think that's really critical for us to continue acknowledging, and stay implicated in the ways that we're connected to things that cause suicide and other types of harm. So our agenda for today is to just talk a little bit about types of lived or living experience, explore who we might be talking about, define what meaningful involvement would look like for people, preparing our organizations for people to be involved, how we implement and evaluate that work, and then some of the common pitfalls, because I've worked in lots of settings where we've done lots of different things with people with lived and living experience, and I've definitely seen lots of mistakes and made lots of mistakes, even as someone who has experience myself. So hoping we can chat a little bit about that to help other folks avoid some of those things. So when I talk about lived or living experience, lived experience is usually about something that happened in the past, and living experience is something that's sort of ongoing for a person. So people might use either of those terms, or they might use something else to describe themselves. But the kind of types of lived or living experience that we might see in our work related to suicide is that someone could be a suicide loss survivor. Um, Suicide loss survivors tend to be better integrated into our work oftentimes than people with other types of lived and living experience, but that's not always the case. Friends, family of suicide attempt survivors, or people who live with suicidal thoughts, suicide attempt survivors, people who experience ongoing suicidal thoughts or behavior, people who are currently receiving services related to suicide, people who might identify as psychiatric survivors, peer workers. So this is people who are providing peer support services professionally. And you also probably have lots of workers in your organization who have lived or living experience, and they may or may not be disclosing that to you. And those folks are in a sort of different role than people who are explicitly in a peer worker role. And I think one of the main differences that you might see is that they're probably paid more in your organization, because we tend to pay people with lived and living experience pretty significantly less than we pay folks with clinical experience. So that's who I'm going to be talking about. I'm going to focus primarily on people who have their own direct lived experience, and not as much on family and friends, although we can talk some about that if that's of interest in the chat. I think that we're just better at including folks who are in the sort of lost survivor category than we are people with direct lived experience, particularly if they're people who are currently experiencing suicide crises or have ongoing suicide crises. So let's start by talking about what meaningful involvement can look like. I think one of the things that happens all the time is that, like, there's a sort of a buzz around something like peer support or including people with lived experience. There's no real direct plan for how you do that, or even when there is a set of recommendations, those recommendations sometimes still feel really vague and don't have good steps for how you actually involve people or give examples. So I wanted to define what makes that involvement meaningful versus sort of tokenizing, and then all of the different ways that you can have people involved. So the first kind of meaningful involvement is paid labor. So this is but the first characteristic of meaningful involvement is that it's paid labor. We shouldn't be exploiting people's experience. So if we would pay a consultant from any other kind of field, we should pay people with lived experience equally. I think it's pretty important to have parity in those wages. I know that that's not typically what happens and can be a little bit hard to pass through systems, but the closer you can get to that, the better. There's really great guidance for that from PCORI, the Patient-Centered Outcomes Research Institute, that talks about how you would pay people with lived experience, which is a federal organization. We have to treat people as experts if they're going to be meaningfully involved in our work. So their lived experiences can't be questioned and they need to be treated as expertise. We want to acknowledge the power dynamics that are happening. So we should be having open and honest discussions of power dynamics between people identified as staff and people identified as having lived experience. It's also helpful to kind of challenge that dichotomy because we might be paying someone as someone with lived experience and the staff that's doing that work could also have lived or living experience. So those dichotomies aren't as real as we would maybe think they are, but people are showing up in different ways based on what they're being paid to do in those settings. One of the most important, honest conversations about those power dynamics is just experiences with coercion. So if you're asking people to participate in any way in your organization who have lived or living experience, and the people they're participating with are people who could potentially write a psychiatric hold on them, there's a pretty significant power dynamic that could cause people to limit the things that they say. So that's always important to not just recognize, but then talk about how do we work with and around that being the case. It's helpful to include diverse perspectives. So we shouldn't be just involving one person with lived or living experience in our work. We should pay attention not only to diversity in terms of the lived experience they have, but also diversity in their identities. People with lived and living experience shouldn't just be selected because they support existing agendas and won't challenge anything. It's most helpful to bring in people who will challenge you and help you do your work better. That's the point of involving people in our work, is so that we can work towards something better together. It's helpful to include people from underserved or underrepresented populations. And but depending on your organization, you can identify what those are. And we should specifically be talking about sort of the dominance of whiteness in our field, and be thinking about that and the ways that that shows up in those rooms. You want to make sure that people are able to have boundaries and that those boundaries are respected. So someone doesn't have to be just an open book to us because they have lived or living experience and are showing up in that way. It's helpful to co-create ground rules or rules of engagement so that everyone gets to be involved in deciding how that can look, how interactions can look. Um, it's really helpful to just talk through some of that so you can see what kinds of ways someone might be activated, making sure there's opportunity for people to express diverse opinions that could lead to maybe disagreement, and that disagreement is honored as a part of your process. You want to make sure you have a process in place for repair if harm occurs. And so we should always kind of go into interactions knowing that there's potential for harm. And I don't mean this because people with lived or living experience are fragile, because I think that's very much not the case, and we don't want to fragilize people. But we know that our systems aren't perfect and people have been harmed by them, and we're working within them. So we might unintentionally cause some of those same harms to be replicated. And as long as we're having honest discussions about that, and then there's pathways to be accountable for that, then those interactions can work much better. You want people with lived and living experience to have actual power to drive decision making. One of the things I've seen quite a lot is that there's like an advisory board in organizations that's got some people with lived experience on it. and things come to that advisory board that maybe have already been decided and they're just looking for a rubber stamp, or the discussions that happen in that advisory board don't actually make it back. So anything that you're doing where you're including people and asking for their input, they should have some kind of power to drive decision making. There should be actionable steps that come out of that process. There should be representation at all levels of your organization, which might already be happening. You may or may not know about that, but I think it's really useful for people to see that folks with lived experience within our organizations can be successful, can be promoted, are valued in all kinds of different ways, and not just maybe as peer workers, who are some of our lowest paid staff members. We want to make sure that we're sort of shifting from paternalism toward autonomy. So making sure that our process isn't designed around us being instructive to people with lived experience, but that the process that we're working through gives people autonomy to make decisions and live the lives they choose. And then we want to make sure that lived experience is considered a credential in our organization. One of my favorite things that we've done at my organization that really changed the way people thought about and engaged with lived and living experience is that we added on our job descriptions having lived and living experience as a credential for clinical staff, for staff in all kinds of other places. It was a really simple change, but it made a really big difference in the way that people interacted with us in our hiring process, and then also once they were on staff. Some of the kinds of roles that you might have people with lived and living experience in for your zero suicide projects could be participating as program evaluators. They could be on your board of directors. I think it's really important not to just have like one seat on a board of directors for someone with lived or living experience. If you're doing that, then it's only going to be one person's perspective. And it doesn't really demonstrate the kind of value that you might want to demonstrate for people with lived and living experience. I think it's always helpful to have at least two. Advisory board members, and again, we want to make sure that if we're using an advisory board, they're actually able to provide advice and guidance that we do something with. They can be research team members, they might be peer workers, and then they can also be involved in community outreach. There are other roles, but I think these are some of the most common and most easily accessible roles for people with lived and living experience. They can have basically any role or position within your system as long as you're ready for that, and if your organization is creating that as a value. So when we start looking at preparing for involvement, I think this is the step that most organizations actually forget to do. Is we kind of decide we're going to have people with lived experience pick a place where they're going to be involved, and then just kind of have people show up, and we don't have good plans in place for how they'll interact and what will happen once they're there. So thinking through this whole process is really useful. You will not predict everything that's going to happen. There are going to be things that come up, things you should have been more prepared for, you wish you were more prepared for, but starting to do some of this work can be useful before someone shows up in the door. So the first thing you'll want to do is plan for involvement. Make sure that what kind of involvement they'll have is very clear, that the rest of your staff knows and is trained in understanding how those folks with lived experience are being asked to show up. You'll want to support and incentivize staff self-disclosure. The reason that we support and incentivize that, or it's useful to support and incentivize that, is because then you're not sort of creating this dynamic where only people who are in lived or living experience roles are expected to talk about their personal experiences, because that can set up a pretty big power dynamic. But if we start to recognize that those lines are not as clear, it can be really helpful. Some of the best ways to support and incentivize self-disclosure is to have people in positions of power who do that on a regular basis, and in a way that the organization values. It's really useful to connect someone's lived or living experience to the value they bring in your organization. So talking about like how this person's lived or living experience makes them a better employee in these different ways, or a better caregiver for the people that we serve in those kinds of ways. You want to make sure you create an orientation and training. And if there's an expectation around self-disclosure from that person, there should be some training around self-disclosure and some of the kinds of vulnerability people can experience after disclosing. You'll want to make sure you're using shared language, and I recommend just developing that with the people who you're bringing in. So we can, come up with whatever terms we might want to use, but people's language is usually pretty regional and then also community driven. So deciding on language together and explaining why we use the language we do in a respectful manner, collaboratively, can be really important. So you'll want to sort of prepare your organization based on the way you all want to talk about it, and then have another process when you're bringing those folks in to talk about how they might want to talk about different things that they've experienced. I think it's really useful to identify someone as an ombudsman or just a sort of neutral person that they can go to for support or to disclose if something isn't going well. Design formal and informal feedback mechanisms so that we're not just requesting feedback when something feels like it went wrong, or that people aren't trying to find ways to give feedback just because something went wrong. There's a sort of ongoing process. And then create really clear goals. And if we meet the goal, you can end the project. You don't have to just keep a project going forever just because you have it already in place. So I don't mean to say that there aren't projects that should be ongoing. I think there's all kinds of things that we want to continue doing sort of for the scope of, or the lifespan of our organization even. But if you have something really specific and clear, having a like beginning, middle, and end, and people's commitment being able to end is really helpful. People coming in to do any kind of consulting or whatever they might be doing generally like to know what their commitment will be. So having an end time is helpful. And then we want to just prepare for things to not go perfectly the first time. We should try things, reflect on them, and then try them again. This should be an iterative process. So you want to make a plan. You create that plan with key stakeholders, including people with lived and living experience if you can from the outset. Make sure you're ready to pilot that plan, and then do it for a designated amount of time, including data and feedback mechanisms. And then take the time to evaluate it and then actually make adjustments based on your evaluation. So I think oftentimes we kind of skip the step of making the adjustments after we evaluate something. So create a formal process for inviting feedback and analyzing outcomes, and then make changes to your plan, policy, process based on it, and then kind of go through that circle again. And just go into the process knowing that there are going to be things that don't go the way we wanted to the first time, and that doesn't mean that the project is a failure. It just means that we have more to learn about how to do this effectively. Some of the really common pitfalls that I think people experience, and perspectives and practices that can cause some of those common pitfalls, are that we know that people with lived and living experience can be harmed. And these are the sort of things that create harm for folks. It's not that folks are sort of vulnerable necessarily. It's really more to me about how we are using power within our organization if we're creating vulnerability for people. So if we're dishonest about power and those dynamics, we really can't do this work effectively. It's sort of a setup for harm to be caused. When we are sort of expecting people to engage in different ways and not being honest about that dynamic, it sets up an experience where that person can feel really tokenized or exploited, and people who are having that experience are not very likely to be honest and really participate effectively in whatever we're trying to do. Harm also happens when we lack accountability processes. So I think sometimes we set up a standard for ourselves of doing things perfectly the first time, which is a really common sort of experience in, I think, clinical settings, is that we have these kind of standards that we're supposed to live up to, but we know in actual practice that's not how things work. If we go in knowing that in our practice we're going to make mistakes, then we can build processes around that in advance so that when those things happen, um, we have a pathway for doing something differently instead of just having sort of a project blow up and not work out. Um, if you are including people without decision making power, that's tokenism, and there's no accountability there. So I think that's really important. Is that, like, if you're going to have people involved, you need to have them in a position where they have some kind of decision making power, or the things that they're doing are actually going to contribute to something evolving in the future. So oftentimes in research projects and processes, you'll have like focus groups or surveys where we extrapolate information from community stakeholders, but then there's no clear next steps or how this information will be used, or what will this intervention we're creating look like. That feels pretty disingenuous and taxing for folks, especially if there isn't clear accountability of the research or the findings or how things will be implemented. So we both want accountability processes for the project itself and then for individuals and their interactions. If we tokenize people, their experience is not great with us, and this happens all the time. Just because I think oftentimes we get funding for something, or we create a pilot and we're just having one person involved, or just one group. We're going to have one focus group. My best recommendation, I think, is that we try lots of things, and that there's always at least two people with lived or living experience involved, so that they're not the only one trying to speak on behalf of all other people with lived and living experience. Um, it's harmful if we only select people who agree with us. So I think the really critical part to me here is that we know that there are kinds of interventions that work for many suicidal people, and they don't work for all people. But what tends to happen is we include the people who affirm our practices as they already exist, instead of looking at folks who are being missed by our services, or being harmed by our services, or having a bad experience with our services. So we sort of create this situation where the only people who get to be involved are people who are going to tell us what we want to hear. Um, we've done that for a pretty long time, and we haven't really impacted suicide rates in any meaningful way. So it's probably a good time for us to start involving the people who think that there might be something that's not going as well, because we haven't been able to figure it out on our own. And I think if we are going to solve the problems that lead to suicide, there's no way for us to do that alone, or just thinking about things in the way that we think about them without involving other perspectives. People can be harmed when we fragilize them. So if we treat people like they can't handle things, that means we leave out really valuable, important information. We often keep them out of positions where they can make decisions. And if we have a process that's going to involve people in or expose them to coercion, that's pretty. It can create a really difficult dynamic. So that's a central component of what we do in clinical settings. And so I'm not suggesting that you're going to be able to change or end all coercion in your settings. That's not something that's likely to happen. When I'm talking about coercion, I mean any kind of involuntary treatment. I think there are other things that can be coercive, but that's kind of what I'm getting at here. Um, you have to be honest with people about how coercion exists as a part of what we do, and make sure that people have really, really clear guidelines so they can make choices about how they show up and participate in your organization based on what might happen to them. So if you're doing research or focus groups or whatever with people with lived experience, it should be very clear to them that if they disclose certain things, they could have something happen that might be involuntary, things like that. You should also have some conversations and processes around when it's appropriate to be assessing people, because very likely in the situations we're talking about, people with lived and living experience are not showing up for treatment from us. They're showing up as partners in our work. And there's not any kind of mandate that says that you should be doing assessment or trying to figure out if someone needs clinical care as a coworker. So I think it's really important to sort of differentiate those things. And people can be meaningful participants in our work when they are experiencing crisis. Those are the people that we talk to the least about what we do, even though they're the people that we interact with the most in our systems. So we kind of treat people who are in that experience as if their perspectives aren't real or reliable or trustworthy or maybe don't matter. So it's really important to sort of differentiate those things and create space for people to engage in different ways in our organization. Some practices to try and resist would be having peer workers reporting to clinical staff. This is a pretty common occurrence, but it is really helpful to have departments of peer supporters who report to other people who are peer workers, not just clinicians with lived experience, people who professionally do peer support. In our organization, we have a value around that, and people from our peer specialist team all the way up to me on the executive leadership team report to someone who has lived experience. They're not reporting to clinical staff. That doesn't mean that clinical staff don't have things to offer people, but the practice of peer support is something different. And people should be getting coaching, feedback, support around peer work, not around clinical work. We want to resist having one person representing all lived or living experience. Or even if we do have one person providing feedback or participating in our organization in this way, recognizing that they are just one person, then they don't represent everyone. We want to avoid segregating lived and living experience initiatives. So we don't want to treat them as like some kind of special project. They should be integrated into our systems in the same way that other kinds of practices are. Avoiding perfectionism is helpful. I think this is just useful in spaces that are white dominated, which most clinical worlds are. But our perfectionism pushes us to do things that are not particularly useful when we're trying something new. When we're perfectionists, it causes us to avoid things because we think they won't work out, and then also to kind of smooth over or cover up when things don't go as well, instead of directly addressing what's going wrong so that we can improve. Clinical fragility. So I have had lots of experience where clinical staff are feel some kind of struggle with people with lived or living experience providing feedback, particularly if they're providing feedback that is critical of clinical work. And I think it's important for us to remember that it's not those kinds of feedback aren't judgments about us as individual people, and that we all have areas where we can improve, and we can't know that, like we can't keep ourselves like fabulous in our work on our own. We need other people to help us stay fabulous. So we need to get feedback for that to happen. Having resistance to critique is not helpful. And then co-optation, and I think this is really important, is that peer workers, because peer work has been inconsistently defined by different organizations and government agencies, things like that. Oftentimes, we have sort of clinical oversight of a peer program, and peers end up doing kind of behavioral health tech work, and that's not what peer support is. So peer support is its own separate practice, and I have lots and lots of documents that I don't know if you all got them already or if you'll get them afterwards, that give you some guidance on what peer work should look like, and some organizations that you can go to specifically for peer support practices in crisis kinds of settings. So there's Alternatives to Suicide, Hearing Voices Network, and Intentional Peer Support, which are sort of the three practices that I think do a really great job of addressing crisis type situations. So it's not just the peer support that you might see in other spaces that's a little bit like in spaces with less acuity. All right. So then I just have a quote from Sherry Mead, who's from Intentional Peer Support, who says peer support is a culture of healing as people practice new ways of being through even the most difficult times. Possibilities for breaking old patterns and creating new opportunities are endless. Crisis then just becomes another word for redefining our experience and ourselves so that instead of needing to be locked up, we can begin to break free. Um, I know I went through stuff a little bit quickly, but I wanted to make sure there was some time for comments and questions because usually folks have quite a few on this topic. So I'm going to just stop the share so I can see folks if they want to talk, to ask questions, or I can see the chat a little bit more easily.
Yeah, thank you so much, Jess. We did have 2 questions come through the chat. One was from Rebecca. Some people are embarrassed to speak up about this. I think that this at that point in the presentation was talking about their experience. Do you have any suggestions on how to find someone in a respectful, kind manner?
Yeah. So I think there's pretty good reasons that people are nervous to speak up about it. So I think that's where you need to start. So what's going on in your organization that makes people feel uncomfortable or nervous? And it might not be just your organization, right? We live in a whole world that has a context around this that makes people scared, right? If they went to a clinical program, they might have been told in their clinical program that if they have lived or living experience, that it's a problem in their work that they need to manage, things like that. So there's a whole context around that, but I think identifying what might be the barriers for someone or what might make it unsafe within your organization is a good starting place. So you can have there are lots of approaches to doing that. I think you can do things like surveys. You could do focus groups where you're just talking about what might make it difficult for someone to disclose in this environment, and then what are the benefits of disclosure. So you can have those conversations with your teams where you're not actually asking anyone individually to disclose anything. It's opening up the space for that disclosure.
Yeah, thank you. And Rebecca, feel free to follow up. But that's really helpful. Thank you. Another question, I know you can see the chat too, was from Laura. I recently reviewed information from one of our peers that they were told by a peer organization that they would never do a risk assessment. That it is a power down situation and peers do not do that. Couple of questions then. Surely a risk screening can be done in a way that is not power down, and if it's life or death, isn't that still more important to get the screening or assessment done?
So I don't think it's more important to get screening and assessment done. I think that screening and assessment is a clinical intervention and should be done in clinical work. Peers have other ways of engaging around suicide and other kinds of safety concerns. I think that risk assessment is one method. It is the research about risk assessment isn't great. We're not actually very good at predicting risk. We're pretty bad at it. It's about flipping a coin. So the idea that risk assessment is the only way or the most effective way is sort of based on things that aren't necessarily true. So I don't think that means that risk assessment can't be useful. I teach people how to do. I taught a whole PsyD class on suicide and risk assessment this summer. So I think there's utility in that, but it is a clinical intervention and not a peer support one. So I don't think that means that peers should be passing people off to clinicians because they're suicidal either. There's other ways of engaging around suicide. Just talking about what their experience of suicide is, exploring alternatives, understanding the meaning that it has in their life. All of those things are useful interventions. And our interventions are actually the things that have the most evidence base. Like risk assessment has a pretty poor evidence base. And oftentimes we treat it like that is the intervention, and it's not. That risk assessment doesn't help anyone except the clinician. So I think it's important to remember that since we're not very good at predicting risk to begin with, if we just move on to exploring other ways of being for that person, we can probably create a pretty big difference for them.
Definitely. Thank you. Very helpful reminders. Follow up to Rebecca's question from Sarah in the chat. How can folks with lived living experience know when it's safe to disclose in their workplace?
That's a good question. Um, so I don't think you can always be sure. I think that you can be surprised. both in positive and in negative ways. So I think if you see people in positions of leadership who are disclosing on a regular basis and in ways where it's like directly tied to their work and they're being respected as experts because of that experience, then there's a better chance that that's a good safe space for you. Um, it's really helpful to explore what it's like with your immediate team also. So how are they talking about people? This might be something just useful to try with your teams too, is to just shift some of our language. A lot of the ways we talk about people who are experiencing suicidal thoughts or suicide crisis are pretty demeaning. And so that creates a space that's not particularly safe. So if we can start challenging some of those things, I think that can be helpful as well. But exploring what it's like, what people are talking about people who experience crisis are like, and then sometimes it's just, I think it's helpful to sort of explore like hypothetical kinds of situations or ask people what they think about people who have lived and living experience. You can be pretty direct about that before you disclose your own. I guess I'm in a position where it's like my experience is very, very public. And so for me, I have conversations in an interview about that, about like, is this something that you would make me be quiet about at our organization? Am I allowed to disclose or not? What do you think the benefits are of disclosure? Things like that. You can screen yourself in too, if that's something that's important to you.
Definitely, thank you. Steve had a question. Would you please say a bit more about peer workers supervision? What has been found to be the most helpful supervisory structure?
Yeah. I really like a practice that's called co-reflection. It's a practice that's used in intentional peer support. So I think I want to just differentiate kinds of supervision for a second here. So there's sort of organizational administrative supervision that's going to be about like, are you meeting your program goals and things like that? That supervision can kind of be performed by anyone. But if it's supervision that's about someone's practice in the way that you would go and get clinical supervision, that should be done through a co-reflection practice, which is a practice where we bring situations where we struggled and things like that into dialogue together where we problem solve through that together. So there's guidelines for it. There's a co-reflection manual on the Intentional Peer Support website that's free to download.
Definitely. And we'll send out the links and other materials that you passed along post meeting so folks can access those. But thank you so much for that presentation. There's no more questions in the chat, but if folks have them, we have a couple minutes for some more questions. So please feel free to drop those in the chat. I don't want to volunteer your contact information, Jess, but
oh yeah, you can have my contact info. I will put that in the chat too.
Okay, sounds great. We can do that. And if you have any follow-up questions following the collaborative, please feel free to reach out to us at OSP and we're happy to direct your question or tell you if we know about a resource. I'm going to go ahead and share my screen and move forward with some OSP updates, additional resources. One moment. And I apologize also, the construction happening on my street is prolific today. So if you can hear the cars out there, I apologize. Just wanted to flag a couple. Are people seeing my screen at the moment? Hope so. Yes. Okay, awesome. Thank you. Additional resources relevant to this is SPRC's toolkit for activating folks with lived experience. Linked there. Please feel free to check that out post meeting, as well as the EDC's Zero Suicide website for toolkit and videos. I'll show you a preview of that on the next slide. And as Jess said, and as a reminder, this expertise already exists in your community, your meetings, your hospital rooms, your friends. Tap in, it's all there and is how we're really going to transform organizational cultures around suicide. Just flagging that suicide toolkit on the Zero Suicide website. So a whole bunch of resources and information on there that you can see listed. as well as videos relevant to certain topics within that. In addition to just being best practice, involving lived experience in your suicide care pathways tangibly improves quality of care, the impact of your mental health services, your ability to develop innovative approaches that more capably reach patients where they are, communication and safety and mental health treatment, and ultimately support and recovery for both suicide attempt and loss survivors. So to that end, we also have some other updates and resources from OSP. First is a veteran-ready military cultural awareness training, can be accessed at that link. We also are still offering that START Gatekeeper training on our Colorado website, the CDPHE one listed there. We have a suite of hard copy materials and the Colorado Zero Suicide website as well. So please feel free to click through those links as they're helpful to you. And if you need any clarification with any of those, please feel free to reach out to us. Thank you so much for meeting today with this LC. We're gonna hang around until 11 here just for any lingering questions, comments, concerns, but our next meeting will be September 23rd at 10 a.m. I am also going to post the link to a brief survey in the chat about availability for these meetings, just to make sure that everybody who wants to come is still able to. But if you have a conflict with these meetings on the fourth Thursday of every month at 10 a.m., please also just feel free to drop that in the chat now or unmute and we can talk about that. But thank you, Jess, again for presenting today. That was amazing. Lots of good info. We'll be sure to follow up. And thank you all for being here. Looking forward to seeing you next time.
Thank you.